Welcome to this postgraduate clinical review on neuroinflammatory myelopathies and overlapping syndromes. This is a clinically important and high-yield topic because acute inflammatory spinal cord syndromes often present as neurological emergencies, and early diagnostic accuracy has a direct impact on treatment, relapse prevention, and long-term disability. In this session, we will take a structured approach to inflammatory myelopathies, focusing not only on acute transverse myelitis itself, but also on the broader overlapping syndromes that commonly mimic or encompass this presentation. By the end of this session, the goal is to have a practical framework for recognizing clinical patterns, interpreting investigations, differentiating between key syndromes, and understanding management decisions relevant to both postgraduate examinations and real-world neurology practice. We will approach this systematically. We begin with the foundational definitions and the broader neuroinflammatory spectrum. We will then explore pathogenesis and epidemiology, followed by the core clinical presentation and specialized signs that help distinguish different syndromes. After that, we will move into classification, investigations, biomarkers, and formal diagnostic criteria. We will then compare MRI imaging patterns across the major neuroinflammatory disorders before discussing acute treatment, long-term maintenance strategies, prognosis, and key examination pearls. This topic is particularly important because similar spinal cord presentations may reflect fundamentally different diseases requiring very different treatment strategies. Let us begin with terminology because this is an area where conceptual clarity matters. Myelopathy refers to a clinical syndrome resulting from spinal cord dysfunction. Patients may present with combinations of motor weakness, sensory disturbance, or autonomic dysfunction depending on the level and extent of spinal cord involvement. Myelitis, by contrast, refers specifically to inflammation affecting the spinal cord. Acute transverse myelitis, traditionally abbreviated as TM, describes a rapidly evolving acquired neuroinflammatory spinal cord syndrome producing segmental neurological dysfunction. However, an important modern concept is that acute transverse myelitis is often not the final diagnosis. Instead, it is better understood as a clinical presentation within a broader neuroinflammatory spectrum. That spectrum includes multiple sclerosis, neuromyelitis optica spectrum disorder, or NMOSD, MOG antibody-associated disease, or MOGAD, and acute disseminated encephalomyelitis, or ADEM. Each of these conditions has distinct immunopathology, prognosis, and treatment implications. This is why every patient presenting with inflammatory myelitis requires further diagnostic classification rather than simply being labeled with transverse myelitis and left there. An additional conceptual point concerns nomenclature. The word transverse implies complete involvement across the width of the spinal cord. In reality, many inflammatory lesions are partial, asymmetric, or anatomically selective. For that reason, future terminology may shift towards simply using the term myelitis rather than transverse myelitis. Epidemiologically, these conditions are uncommon, with incidence estimates around 1 to 9 new cases per million annually, but their consequences are potentially severe. Although these syndromes may look clinically similar, their immunopathology differs significantly. Understanding this matters because treatment choices depend on the underlying biology. In idiopathic inflammatory myelitis, the presumed mechanism is autoimmune inflammation, often triggered by molecular mimicry following a preceding infection. Respiratory or gastrointestinal infections are reported in a significant proportion of cases. In multiple sclerosis, the dominant process is a T-cell-mediated autoimmune cascade. This leads to focal CNS inflammation, demyelination, oligodendrocyte injury, and progressive axonal loss over time. In neuromyelitis optica spectrum disorder, the pathology is fundamentally different. This is an antibody-mediated astrocytopathy. Aquaporin 4 antibodies target astrocytic water channels, triggering complement activation, astrocyte destruction, and severe inflammatory injury. This distinction is important because therapies effective in MS may not only fail in NMOSD, but may actually worsen disease. In MOG antibody-associated disease, the immune target is different again. Here, antibodies are directed against myelin oligodendrocyte glycoprotein, located on the outer surface of the myelin sheath. This results in inflammatory demyelination, often with relative preservation of axons compared with some alternative syndromes. Finally, ADEM is usually a post-infectious autoimmune inflammatory syndrome characterized by multifocal perivenous inflammation and demyelination. The practical takeaway is straightforward. The same clinical syndrome, acute myelitis, may reflect entirely different disease mechanisms. The clinical presentation of inflammatory myelopathy is often built around three major domains. First, motor dysfunction. Patients commonly present with rapidly progressive weakness, most often paraparesis, although cervical lesions may produce quadriparesis. Early in the course, the spinal cord may enter a phase of spinal shock, characterized by flaccid weakness and reduced reflexes. As the acute phase evolves, upper motor neuron signs become established. Examination may then reveal hyperreflexia, spasticity, clonus, and extensor plantar responses. Second, sensory dysfunction. Patients frequently describe numbness, paresthesia, altered sensation, burning discomfort, or dysesthesia. A particularly important examination finding is the presence of a sensory level. This is highly localizing and strongly supports spinal cord pathology. Third, autonomic dysfunction. This may present surprisingly early and includes urinary urgency, urinary retention, bowel dysfunction, incontinence, and sexual dysfunction. A particularly useful examination concerns time to NADA. If maximal neurological deficit develops extremely rapidly, within under 4 to 6 hours, vascular spinal cord infarction becomes much more likely than inflammatory myelitis. By contrast, if deterioration progresses beyond approximately 3 weeks, inflammatory causes become less likely, and alternative diagnoses such as neoplastic, infiltrative, metabolic, or sarcoid processes should be considered. Classically, inflammatory myelitis reaches its nadir between 4 hours and 21 days. This temporal framework is extremely useful in examinations and real practice. Certain clinical signs provide important diagnostic clues because they strongly suggest specific underlying syndromes. One classic sign is Lermit sign. This is described as an electric shock-like sensation radiating down the spine or into the limbs when the neck is flexed. It reflects cervical spinal cord involvement, particularly dorsal column dysfunction, and is classically associated with demyelinating disease, especially multiple sclerosis. Another useful sign is McArdle sign. This refers to worsening pyramidal weakness with neck flexion and is considered relatively specific for cervical cord dysfunction in multiple sclerosis. Although not routinely tested formally in every examination, it remains a useful postgraduate teaching point. A particularly high-yield syndrome to recognize is area post-Rheuma syndrome. Patients may present with unexplained persistent hiccups, intractable nausea, or recurrent vomiting without an obvious gastrointestinal cause. This reflects dorsal medullary involvement and is highly characteristic of NMOSD. Recognizing this symptom cluster can dramatically shorten time to diagnosis. Another important clinical pattern is Brown-Sequard syndrome. This results from a partial hemichord lesion. Clinically, patients demonstrate ipsilateral upper motor neuron weakness and loss of proprioception, alongside contralateral loss of pain and temperature sensation. This asymmetric presentation may be seen in partial inflammatory cord lesions, particularly in multiple sclerosis. Finally, when considering ADEM, the presence of encephalopathy becomes important. In pediatric diagnostic criteria, encephalopathy is required. In adults, it is less consistently present, but remains a useful differentiating clue when multifocal inflammatory disease is suspected. The major principle here is pattern recognition. Certain symptom clusters strongly shift diagnostic probability before investigations even begin. Inflammatory myelopathies are best classified along two independent axes. The first is etiology, the second is MRI extent. Beginning with etiology, one category is idiopathic inflammatory myelitis, where no definitive cause is identified despite appropriate investigation. This remains a diagnosis of exclusion rather than a primary diagnosis of convenience. A second major group includes secondary CNS demyelinating disorders, specifically multiple sclerosis, NMOSD, MOGAD, and ADEM. Systemic inflammatory diseases must also be considered. These include systemic lupus erythematosus, Sjögren's syndrome, sarcoidosis, Behçet disease. Infectious causes remain important, particularly herpes viruses, varicella zoster, tuberculosis, syphilis, Lyme disease, and less commonly parasitic infections. Paraneoplastic inflammatory myelopathies should also be considered, especially when presentations are atypical, progressive, or associated with systemic red flags. The second axis is MRI extent. This distinction is clinically extremely useful. Acute partial transverse myelitis typically involves less than 50% of the spinal cord cross-sectional area and extends across fewer than 3 vertebral segments. These lesions are often asymmetric and strongly associated with multiple sclerosis. By contrast, longitudinally extensive transverse myelitis, or LETM, refers to lesions spanning 3 or more contiguous vertebral segments. This pattern strongly suggests alternative diagnoses such as NMOSD, MOGAD, or occasionally ADEM. MRI morphology therefore becomes a major diagnostic discriminator. Acute inflammatory myelopathy is a neurological urgency, and the diagnostic approach should be structured and efficient. The first priority is urgent spinal MRI, ideally imaging the entire cord. This serves 2 critical purposes. First, excluding extraaxial compression such as epidural abscess, tumor, or hematoma. Second, confirming inflammatory cord involvement and characterizing lesion morphology. Lesion length, axial distribution, enhancement pattern, and conus involvement all provide valuable clues. The second investigation is brain MRI, which should be performed in essentially all patients. This helps assess dissemination in space and identify syndrome-specific patterns. For example, multiple sclerosis commonly shows ovoid periventricular lesions, often referred to as Dawson fingers. By contrast, NMOSD may demonstrate periependymal lesions or area postrema involvement. The third major investigation is CSF analysis. Markers suggesting inflammatory pathology include pleocytosis, elevated protein, elevated immunoglobulin index. CSF interpretation can also help refine differential diagnosis. In multiple sclerosis, pleocytosis is usually modest, often under 50 white cells per cubic millimeter, and oligoclonal bands are commonly present. In NMOSD, CSF pleocytosis may be more pronounced, sometimes with neutrophilic predominance, while oligoclonal bands are often absent. In MOGAD, oligoclonal bands are uncommon. The fourth step is targeted serological testing, which we will discuss next. Targeted antibody testing is often decisive. This is one of the most important modern shifts in inflammatory myelopathy diagnosis. Patients with LETM or severe inflammatory myelitis should undergo mandatory testing for AQP4-IgG and MOGIGG, ideally using validated cell-based assays rather than less reliable methodologies. A positive AQP4 antibody strongly supports NMOSD. This is clinically critical because NMOSD often requires aggressive relapse prevention immediately after diagnosis. A positive MOG antibody supports MOG antibody-associated disease, which has different prognostic and treatment implications. A major diagnostic trap is misclassifying NMOSD as multiple sclerosis. This can be harmful because some MS disease-modifying therapies, including agents such as fingolimod or natalizumab, may worsen NMOSD. That is not a theoretical concern, it has real clinical consequences. If LETM is present but both antibodies are negative, alternative diagnoses must be actively pursued. This includes sarcoidosis, systemic inflammatory disease, infection, and paraneoplastic syndromes. A key practical rule is this: whenever severe inflammatory myelitis is suspected, define antibody status before committing to long-term immunotherapy where possible. Formal diagnostic criteria differ across syndromes, but understanding their logic is more important than memorizing every detail. For acute transverse myelitis, traditional consortium criteria require bilateral motor, sensory, or autonomic signs, a clearly defined sensory level, objective evidence of inflammation, and symptom progression to nadir between 4 hours and 21 days. Alternative explanations, particularly compression, must be excluded. For NMOSD, the 2015 revised criteria depend partly on antibody status. In aquaporin 4 positive disease, a single core clinical syndrome may be sufficient. Examples include LETM, optic neuritis, area post-Riemer syndrome, brainstem syndromes. In antibody-negative disease, diagnostic thresholds are stricter and require dissemination across multiple core syndromes plus supportive imaging findings. For MOGAD, diagnosis requires a compatible core demyelinating syndrome, clearly positive serum MOG antibodies, and exclusion of alternative diagnoses, particularly multiple sclerosis. For ADEM, diagnosis requires a first multifocal inflammatory CNS event, presumed inflammatory cause, and encephalopathy not otherwise explained. The larger message is that inflammatory myelopathy diagnosis increasingly relies on combining clinical syndrome recognition with imaging and biomarker confirmation. Magnetic resonance imaging is one of the most powerful tools for differentiating inflammatory myelopathies because lesion morphology often reflects the underlying disease process. In multiple sclerosis, spinal cord lesions are typically short segment, involving fewer than 3 vertebral segments. They are often multiple and tend to occupy peripheral regions of the cord, particularly the dorsal or lateral columns. On brain MRI, the classical finding is ovoid periventricular lesions, often described as Dawson fingers, reflecting demyelination along medullary veins. This pattern strongly supports multiple sclerosis, particularly when acute partial transverse myelitis is present. In neuromyelitis optica spectrum disorder, the hallmark spinal pattern is longitudinally extensive transverse myelitis, meaning lesions extending across 3 or more vertebral segments. On axial imaging, lesions often occupy the central cord and may involve more than 70% of the cord cross-section. A descriptive feature sometimes mentioned is the presence of bright spotty lesions on T2 imaging. Brain MRI may show lesions involving the area post-Riemer, periependymal surfaces, or other aquaporin-rich regions. In MOG antibody-associated disease, lesion length is more variable. A notable clue is conus medullaris involvement, which is relatively characteristic. On axial imaging, one important pattern is the H sign, reflecting preferential grey matter involvement and producing a butterfly-like appearance. Brain MRI may show fluffy ADEM-like lesions, and a useful prognostic pearl is that MOGAD lesions often resolve more completely than those seen in NMOSD or multiple sclerosis. In sarcoidosis, imaging may be more variable. Lesions may be long or short, but one important sign is the trident sign, representing dorsal subpial enhancement with central canal involvement. Supportive systemic imaging may reveal mediastinal lymphadenopathy. The key principle is simple. Lesion shape, length, axial location, and associated brain findings often narrow the diagnosis dramatically. Management of acute inflammatory myelopathy should be prompt and decisive. Delay risks irreversible axonal injury and permanent disability. First-line therapy is high-dose corticosteroids. Standard treatment is intravenous methylprednisolone, 1 gram daily for 3 to 5 days. Some settings may use dexamethasone, but methylprednisolone remains the most familiar standard approach. The objective is rapid suppression of inflammatory activity. However, an important teaching point is that steroids accelerate recovery rather than guarantee full neurological recovery. If deficits are severe, particularly significant motor impairment, or if there is inadequate response to steroids, escalation to plasma exchange, or PLEX is indicated. This is especially important in antibody-mediated disorders, such as NMOSD, where removal of pathogenic circulating antibodies may substantially improve outcomes. Timing matters. Earlier plasma exchange is associated with better recovery. A practical clinical principle is that treatment should not be unnecessarily delayed while waiting for every investigation to return. When severe inflammatory myelitis is strongly suspected, urgent anti-inflammatory treatment and diagnostic refinement often proceed in parallel. Supportive management is equally important. This includes urinary catheterization when retention is present, bowel management, venous thromboembolism prophylaxis, pain control, early rehabilitation input, pressure area care in severely impaired patients. Acute management is therefore not just about immunotherapy. It is comprehensive neurorehabilitative care from day one. Long-term management depends entirely on the underlying diagnosis. This is why correct classification matters so much. In AQP4-positive NMOSD, relapse prevention is critical because each attack may leave substantial permanent disability. Approved targeted therapies include eculizumab, ravulizumab, satralizumab, inebilizumab. These reflect modern precision therapy directed at complement pathways, interleukin-6 signaling, or B-cell depletion. An extremely important clinical warning is that certain multiple sclerosis disease-modifying therapies may worsen NMOSD. This includes agents such as fingolimod and natalizumab. Misclassification can therefore be dangerous. In MOGAD, relapse patterns differ. Many patients require prolonged corticosteroid tapering, often over several months, to reduce early relapse risk. In recurrent disease, therapies such as rituximab, mycophenolate, or maintenance intravenous immunoglobulin may be considered. In multiple sclerosis, long-term disease-modifying therapy is guided by standard MS treatment principles and depends on disease activity, MRI burden, and relapse history. In idiopathic inflammatory myelitis, no universally established maintenance therapy exists. These patients require close longitudinal monitoring because some will later declare an underlying definable syndrome. The major principle is straightforward. Treatment follows diagnosis, not the other way around. Prognosis varies significantly depending on the underlying syndrome, severity at presentation, and speed of treatment initiation. A traditional teaching concept is the rule of thirds. Approximately one-third of patients recover well, one-third retain moderate disability, and one-third experience severe long-term impairment. Although imperfect, this remains a useful conceptual framework. Several factors increase relapse risk. These include a QP4 antibody positivity, persistent MOG antibody seropositivity, brain lesions suggestive of multiple sclerosis, and positive oligoclonal bands. One encouraging point in MOGAD is that lesions often demonstrate more complete radiological resolution, reflecting relative preservation of axonal integrity compared with some alternative disorders. Several examination pearls are worth reinforcing. If symptom progression reaches maximum deficit in under 4 to 6 hours, think vascular spinal cord infarction. If progression occurs over 4 hours to 21 days, inflammatory myelitis remains likely. If progression extends beyond 3 weeks, consider neoplastic, infiltrative, sarcoid, or metabolic causes. Another key point concerns ADEM. In pediatric populations, encephalopathy is required diagnostically. In adults, it is less consistently present. And finally, perhaps the most important practical message of the entire session: misclassification between multiple sclerosis, NMOSD, and MOGAD is not an academic error. It directly affects therapy, relapse prevention, and permanent disability outcomes. Neuroinflammatory myelopathies represent one of the most diagnostically challenging but clinically rewarding areas in neuroimmunology. A structured approach based on syndrome recognition, MRI pattern analysis, CSF interpretation, antibody testing, and early treatment allows more accurate diagnosis and better outcomes. For postgraduate examinations and real clinical practice alike, the key is disciplined pattern recognition rather than memorizing isolated facts. Thank you for joining this clinical review.